Hi, it's Tom here from Running Physio. Today I want to talk to you about some taping techniques that we can use for patients with patellofemoral pain. We're also going to dive into some of the reasons why we might choose to tape, when we might choose not to, and how we want to align it with the rest of our treatment process. I've also put a link to a selection of free videos that you can access, including a cracking series on iliotibial band syndrome. So do check that out. Visit the Clinical Edge page. They are free. Okay, so let's start with trying to think, well, why would we actually want to use tape for a patient with patellofemoral pain? When's it going to be indicated? Well, I think it's probably most useful for those patients with particularly irritable symptoms. And perhaps those symptoms are then forming a barrier to them being active, doing the sport they love. They may be forming a bit of a barrier to their rehab. In that situation, then, I think it's reasonable to see if some tape might help to calm things down, might help them to stay active, may help them to engage more in their rehab. We know pain is a significant barrier to sport, but it's also a significant barrier to rehab as well. So if we can use it as a strategy to address that pain, brilliant. So I think that can be when it's indicated, but we also want to see that it's effective. So I think if we can see a clear change in pain with an aggravating movement that the patient has identified when we use the tape, that again cements this idea that it's going to be useful for the patient. So typically with patellofemoral pain, this might be things like squatting or single leg squats. It might be going up and down stairs. Typically for us, of course, treating runners, it will be running. So we'd want to try a taping technique and see if it changes one of these aggravating factors within clinic. Now, looking around the research, we might hope to see a fairly clear change in pain. So if we're looking at a 10-point pain scale, we want to see at least a 2-point reduction in pain to know that that's going to be clinically significant. So if you've got a patient with pain during single leg squat, maybe they're scoring it 5 out of 10, you put some tape on, it's down to maybe 2 out of 10 during that activity. For me, that gives you some evidence that is changing their symptoms, at least in the short term, and we can support continuing to use that for a while to calm things down. The opposite is also true. If it doesn't affect their pain, if we're not getting a significant change in their symptoms during any of these aggravating tasks, it's hard to justify keeping the tape on if it's not really changing anything. So if they're irritable and the tape changes their pain and we're able to demonstrate that objectively, I think it's reasonable to try some tape. We may also reason through that perhaps it's going to change their movement pattern in a way that may also reduce pain, perhaps by reducing load on sensitive tissue. So we might use taping to facilitate that. And then the test is to see, well, does it actually change their movement pattern? Does it change their running gait, for example? Ultimately, we want to see if it helps symptoms, but we may also justify its use if it's changing pain to reduce the load on sensitive tissue or reduce that experience of symptoms. So those are some of the reasons why it might be indicated. We also need to consider when it's not indicated. Now, if you have a patient presenting to you with minimal pain, that can do their rehab exercises, that can do their sport without really having significant limitations unless they're really pushing the distance, it's harder to justify the use of tape. I think it's going to be less effective for them. Quite often in those non-irritable cases, you aren't necessarily going to find a test in clinic that's going to provoke their symptoms that much. And some of the research that's out there tends to show those people with higher levels of pain to begin with are probably going to get more significant effects from tape. So minimal pain, non-irritable cases, less useful. We also need to think about the safety aspects. If there's been any allergic reaction to tape in the past, or if there are any concerns about skin health. Many years ago when I was a junior physio, I worked with a fantastic physio who taped up a patient's foot for plantar heel pain. But that patient had diabetes and they had an allergic reaction to the tape. And unfortunately, that caused all sorts of issues with skin health, which took a long, long time to heal because of the diabetes. So we do need to make sure it's safe before we use it with patients. Make sure there's no reaction, make sure they've got good skin health, no contraindications. We also want to be aware when there might be some signs of dependence on these types of kind of offloading strategies, or when actually someone may benefit from loading more We don't want to be offloading patients all the time. So, example, I saw recently clinically a patient with actually again foot pain rather than knee pain, but he was using tape every single day. He was using orthoses. He was using very cushioned shoes. He was doing everything he could to offload the foot, and actually continuing to tape in that situation wasn't helpful. We needed to get him loading, getting that tissue adapting to load again. So it can be contraindicated in those situations. And finally, on this list of when not to tape is when there are negative consequences. Any of our treatments can have negative consequences, and we need to reason through what those might be. So let's say we've got someone who has a reduction in knee flexion. So they don't have a great deal of range available in knee flexion, and that's a problem for them functionally. We then strap them up with tape in a way that then limits their range because they can't flex because the tape's stopping them. We're not helping them. So if someone's got a loss of range, I wouldn't usually want to tape them up because we don't want to have a negative effect there. So just reason through some of those situations as we would with anybody. We want to see that it suits the individual. Adding to that, we also want to think, how does it align with the rest of our treatment process here, particularly how we describe the tape and what it's doing. So if our messages to the patient are that exercise and activity is helpful, that they don't have any sort of movement sort of faults, if you like, they're not malaligned, we don't want these kind of negative messages going out there. We don't want to then give them tape and say this is helping to realign your knee, because A, that's probably not true, and B, it doesn't really fit in with a positive perception of their body that we want to develop. So I would say we're going to use a little bit of tape to see if it can reduce some stress on the sensitive tissue, just to make movement a bit more comfortable for you. And that's it. It's not about realignment, it's no magic tricks here, and we're going to test to see if it's actually effective for them. We also want to make it an active strategy for the patient where possible, so we might demonstrate it to them, but then also get them to use it themselves. Teach them how to do it so that they're actually able to use that technique regularly and they're in control. So we're empowering them rather than them relying on us. And finally, we're never going to use these tapes in isolation. I really don't want to be sort of taping a patient up and that's it. Particularly with patellofemoral pain in athletes, we need to be looking at load management, our rehab, we might look at gait retraining, we might look at addressing fear of movement, etc. So never on its own. Okay, so those are some overall thoughts on taping with a patient. Now let's have a look at these 3 taping techniques. Now, first up, one that you'll probably be aware of, Mcconnell's medial glide tape. This is a taping technique that's been used for many, many years, and there is some evidence to show it can help with patellofemoral pain. Now, this is images taken from Pelletier et al.'s paper. The typical technique here is we're going to use tape and we're going to apply it with a medial glide to the patella as we apply it. Now here we've got some Leuco tape, I think it is, a firm tape being used, but some studies have also had reasonably good results with your kind of sports tape, kinesia tape type options. So it does depend on what the patient tolerates, what seems to work best for them, and it's a fairly simple technique for us to use. Also, in this same paper, Pelletier et al. Used a slightly more technical tape. This was with a sports tape, a flexible tape. This has got quite a long name, mechanical correction with tension in the base tape. So this involves, first of all, using a lateral anchor around the lateral part of the knee that hopefully you can see there. And then we've got this 50 to 70% stretch of the tape initially to reach the lateral border of a patella. And then you have these 2 tails that go above and below the patella. These are going to be stretched 15 to 25%. Now, I think that's really specific. I don't know how we would measure stretching very specific amounts like that for the tape, and whether it's necessarily to do that. But the reason why I highlight both these options is because within this paper, Pelletier et al., what they looked at is, does it seem to affect movement patterns during running? It's one of the few papers I was able to find that was specific to runners, which, as you know, is kind of the area I'm particularly interested in. Now, they do report some significant effects on running gait movements, but those effects are tiny, in the degree of 1 or 2 degrees of change in knee flexion. So looking at this in other papers, it does seem that the kinematic effects, the movement changes that we're going to see, are going to be pretty small. So it's questionable whether they're going to be clinically significant. But these are two options you could try, and we always go with that test is best approach. Look at a painful movement, apply the tape, see if it changes the painful movement. If it doesn't, we might try an alternative technique. These are both reasonable options that you can try with the patient and see if it changes their pain, see if it changes their movement pattern perhaps. The third option to look at here, from a recent paper from Deng et al., I really quite like this. This is a slightly different approach, I believe based on Mulligan's taping techniques. So this is a tibial rotation taping. So there's two options they've tried in this paper. Now both techniques involve the patient standing with the knee flexed to about 20 degrees. One is an internal rotation taping, which you do with full tibial internal rotation, and the tape then winds round from the kind of fibular head region round around the inside of the knee and up to the thigh to try and create that internal rotation. The other is a tibial external rotation taping. So again, you're standing with the knee flexed about 20 degrees, but this time in tibial external rotation, the tape starts medially and it winds round the other way in this paper from Deng et al. Now, what they did in this paper mirrors what we've talked about so far. They had 3 clinical tests, all of which would quite often be painful for patients with patellofemoral pain. So they had a double leg squat, a single leg squat, and resisted open chain knee extension. And they got them to score their pain without tape and then with either of these 2 taping techniques. And both taping techniques seem to reduce pain, and with significant reductions in pain, typically from around about 4 on the pain scale down to around about 1 or 2. So some reasonable pain reductions using these techniques. Now, what I find quite intriguing about this is that actually of the 2 tapes, what we might expect to be more effective would be the tibial internal rotation taping, because that would fit with this idea that we probably want to try and perhaps reduce that position we often see in patellofemoral pain, where you have hip adduction, sometimes coupled with external rotation of the tibia. So we might want to use this to change that, and we might think that taping technique would be more effective. But in this paper, it was actually the opposite that was true. The external rotation taping was more effective, and they concluded that it's probably more effective not because it changes the movement pattern necessarily. It's probably not kinematic changes that affect the pain. It may be other changes in things like proprioception, muscle activation. It may be changes in terms of the patient's fear levels, their levels of confidence, etc. So it may be that we don't need to necessarily look to change movement pattern. It may even not necessarily be the effect on tissue load that works for the patient. And I think that gives us a little bit of flexibility then in terms of the taping techniques that we can apply. The further advantage of this taping technique is it doesn't cover the knee itself, so it's not going to restrict your range of movement at the knee a great deal. So I think it's quite a nice option for you to try with your patients. Like any studies though, it's relatively small. It's not like a randomized controlled trial, so there are some limitations there to consider. So we've got 3 taping options available for you there. Things like the medial glide you'll be aware of, the mechanical correction taping, which I'm not sure is a great term to use with patients, or either tibial internal or external rotation taping. You can try any of these with the patients if it's safe and appropriate, see what affects their symptoms, and then use that alongside their rehab. We want to make it as individual as possible. So if they're getting pain, specifically doing rehab on the leg press, get in the gym with them, take them up, try the leg press, see if it helps their pain. Does it allow them to lift a bit heavier, to load a bit more? So a lot of this is going to be about testing on an individual basis, maybe trying a couple of different techniques to see what works with the patient and using it to calm things down. As things calm down, then we're often going to want to wean off that tape It's not a long-term strategy we need to use. It's often short-term to facilitate loading, to facilitate sport, maybe get them through an event, and then we want to focus more on our long-term strategies. Okay, I'll put links to a couple of those key papers in the comments afterwards. Do let me know if you've got any questions or anything on this one. And thanks again for listening. Bye for now.